Good afternoon and welcome. This is Kelly Piper with the California Healthcare Foundation, and we're very excited about this presentation today where our colleagues from Los Angeles are going to be talking about their experiences learning about medication-assisted treatment in correctional settings, and we'll be reporting back on site visits what we all took to Rikers Island Jail and to the Department of Corrections in Rhode Island. So the goal today is just to expose you to what we've learned in these settings and to talk about what it would take to get California to the place where anyone can access addiction treatment no matter what their setting of care. Next slide. We're gonna, there's a lot of people on the call, so we have muted all of the lines. We will record this session. If you have questions, please type your question directly into the question and answer box and use the chat feature if you have some logistical issues with either sound quality or other issues. We will make sure to, there's adequate time to respond to your questions. Next slide. So the California Healthcare Foundation has been tackling the opioid epidemic with partners across the state for the last few years. And since California has done an amazing job in dropping opioid prescribing, we almost cut opioid prescribing in half compared to 2010, which is an amazing thing given we had tripled or almost quadrupled prescribing as a nation over the last 15 years. And so because the epidemic is really shifting to be more focused on fentanyl and heroin, with more people dying due to street drug use and prescription opioid deaths are dropping, we are doing an all-out focus on getting medication-assisted treatment into every possible setting. That means getting health plans to step up to make sure that there's enough MAT services in their network, getting primary care providers comfortable with treating addiction, getting buprenorphine or Suboxone into emergency departments and hospitals. And we've got projects in all of these areas, and you can learn more about that on our website. Where we're just launching new work is in jails and prisons, and the Healthcare Services Department of California is very excited to partner with us to get MAT into jails and prisons and into residential treatment and other sites. So again, the goal is every door is the right door and people can get care no matter where they are in the system. So I'm going to hand it off to Donna Struger-Fritsch, who's our colleague from Health Management Associates, who's an expert in correctional health and addiction treatment, and she has been our guide on this journey. So Donna, take it from here.
Thanks, Kelly, and good afternoon to everyone. We're very excited to be presenting this information today. My co-presenters and the people who you're most interested in hearing from are Holly McCravey, who's the Director of Addiction Medicine Services for the LA County Jails, and Dr. Aristu Amendzadeh, who's the Medical Director of Addiction Medical Services at the LA County Jails. The LA Department of Health Services Correctional Services Unit was awarded a technical assistance grant from Kelly Piper and the Healthcare Foundation to examine correctional facilities that have established policies and procedures for MAT and to expand the treatment in the LA jail. So I'm providing, Health Management Associates providing a lot of that technical assistance, and we arranged for site visits for all of us to Rhode Island, DOC, and Rikers Island. We're going to share with you our observations from there and lessons learned, and then Holly and Dr. Amendzadeh will talk about the program that's under development at LA County for Addiction Medicine Services. So just as a backdrop, really in the incarcerated population, substance use disorders and opioid use disorders are very much overrepresented in this population compared to others. Also, it's very important that we consider this because release from jails and prisons is associated with a dramatic increase in death from opioid overdose for those people who did not receive treatment while incarcerated. One recent study showed an almost 13% increased risk of death during the first 2 weeks following release. There are a lot of reasons for that, which I'm sure many of you are familiar with. We view more and more the correctional health system inside a jail as one more stop in the community's network of care. There is a primary care clinic and a mental health service and an SUD treatment capacity in every jail, and it really optimally should be integrated with the community system of care. For many people who are incarcerated, their detention is the first time that they have exposure to and access to treatment. And so the setting is ideal for treating SUD, and warm handoff from a jail to community-based care upon release really can help save lives. I also want to note another recent development that I believe is that we're going to see a lot more of. Jails are challenged more and more because detainees are coming to them on methadone or Suboxone or naltrexone. And those jails that have not had a policy of maintaining people on substance use treatment are the majority of our jails across the country. It has been practiced for methadone simply to be terminated in many cases. Some places will, pretty much everybody maintains pregnant women on methadone if they come in on it. But many places simply withdraw people. And more, that is being looked at as clinically inappropriate. There was a recent letter from the U.S. Attorney in Massachusetts to the Boston Department of Corrections, putting them on notice that the U.S. Attorney views people with opioid use disorders as protected under the Americans with Disabilities Act, and any steps to terminate a medically prescribed treatment of an FDA-approved medication for that condition would be considered a violation of the ADA. So that's a pretty big deal. It's not, it was one letter to one DOC, but nonetheless, the concept of continuation of treatment as an expectation is finding its way into prisons and jails. Hence this conversation today. So, Rhode Island. We went to Rhode Island. The DOC there is unique because it's a unified system covering jails and prisons. It's very tiny. They only have 3,000 total detainees in the whole system. However, in response to the death by overdose of the son of a prominent Rhode Island business owner, the governor took this issue to heart and mandated a statewide comprehensive opioid treatment initiative and allocated real money to it, and then further said half of that money goes into the correctional system. And so they've had, they didn't go through the decision making about should we do this or not. They just had to figure out how. And the Rhode Island DOC, Prisons and Jails, provides all forms of MAT now to pre-sentenced and sentenced detainees. All the detainees are screened for substance use and withdrawal at intake. If they're positive, they take a further screening on the TCU using the TCU-5 instrument. And if they screen positive on that instrument, they have a urine test within 24 hours of their booking, which enables treatment to start. And the urine test is a part of the medical record, not the custody record. Anybody who comes into Rhode Island prison or jail on MAT is maintained. And anybody that's not on MAT is offered methadone, oral naltrexone, buprenorphine inductions, along with SUD treatment services. And they're also offered SUD treatment services under an abstinence model. And that's a really interesting point to us in LA. We've talked about it a lot, and my colleagues here at HMA and I see this all the time. These transitions taking place in the treatment world about whether to consider MAT abstinence or not. And it just depends. But the point, there are many ways to look at that. In Rhode Island, they offer treatment under either model, and they are mutually exclusive. In New York City at Rikers, they are not. But the unique thing about the Rhode Island program is that every inmate's unique treatment objectives are met. We talked to inmates who were on methadone and on Suboxone about their decisions and why one drug was preferable for them over another. It's very interesting that they've chosen to be this patient-centered in their approach. They do not cohort their detainees on MAT into a certain place in the jail and prison system. They're just in general population because they found that cohorting people deters them from treatment, as they're being labeled, if you will. One of their challenges is that the induction process, when we were there last fall, could take up to 5 days to start, which was pretty uncomfortable, 5 days, but they're working to reduce that now. Let me stop and see if Holly or Dr. Menzadeh have anything to add to our Rhode Island experience. Get ready to unmute yourselves as I go through these next couple slides. So in Rhode Island, they cap their Suboxone prescriptions at 16 milligrams a day, and they use the film. They do use Vivitrol close to release date. They do use a separate medication administration line for buprenorphine and for methadone. And because they're such a tiny state, they really have the advantage that the contractor that comes into the jail to provide MAT and recovery services is the NTP, the Narcotics Treatment Program, that will be their community provider on release. And so they have an excellent system for warm handoffs, even when release is unplanned, as is often the case in our jails. About a third of their female detainees are on MAT, and they find that about 3/4 of their detainees released on MAT continue their care post-release. And what you see here is pretty striking. They've seen a 61% drop in opioid overdose deaths after release, just within 1 year of their program launch, and that contributed to a 12% overall drop in overdose deaths across the whole state. Striking, striking outcome. Holly and Aristu?
Well, I wanted to jump in. I wanted to, if anybody is from Rhode Island on the phone, I want to thank them again for their hospitality and their openness and willingness to share everything that they're doing with the inmates there in their jails and prisons. One of the things that they have created is actually a film that we were able to see where they showed how custody and the nursing were working together and how they were administering the Suboxone to the inmates. Our trip to both Rikers and Rhode Island just kind of offered up a lot of things for us to think about and see how we can apply these to such a large system of care that we have here in Los Angeles.
Anything else about Rhode Island stand out to you, Dr. Menzadeh?
No, I think Rhode Island is basically gold standard that we all look up to, and we learned about the system of care and collaboration between the healthcare and the custody, and I think that was striking. One of the major variables and contributes to the success is the collaboration between the healthcare and the custody, and the same with Rikers. And I think these are the messages we're bringing in here to see how we can implement those in our system.
Right. Thanks. So moving on to Rikers Island, very different place. Rikers has 9 jails on the island and 3 in the boroughs, and their average daily population is over 9,000. All the detainees who are found to have an SUD on arrest are taken to a single facility for detox, so they cohort all their detox in one place. Rikers has a very long history and a well-developed methadone system in the city, and as a result, anyone who's released from any of the jails can access methadone the next day without question. They've been at this at the jail. They've been using methadone inside the jail since 1987, and they have a wealth of experience and a large body of research that has shown that the use of induction and maintenance of methadone has reduced HIV and Hep C transmission, increases outcomes for addiction and recovery, reduces their overall health care costs, reduces crime and recidivism. And as of the last 6 months, they've always had a good, strong program for methadone. Methadone has increased a lot, and Suboxone is increasing every day. The average between the August and December of last year was 239 people a day on methadone and 39 people a day on buprenorphine. And they expect the buprenorphine number to increase, though it's a challenge because it's not widely available in the city. So they'll be more probably maintaining people who are coming in and then releasing them back to their source of care rather than inducting people on bupe and trying to find a place that can provide it to them in the short term. They are, in the long term, monitoring this every day and expecting to change what they do to provide the most treatment, the most harm reduction, the best outcome. It's very interesting. The prison system in New York has not yet started maintaining people on methadone, and so there's a consideration at Rikers when someone comes in as to what their charges are, because if they are expected to go on to prison within 45 days or less, and they come in on methadone, they're actually started on a taper, a very long taper that allows them to get off methadone before they go to the prison, which is pretty interesting. Everybody else that comes in on it can stay on it. They use the pill form dissolved in water on Rikers, not the liquid methadone. They use a separate medication administration line for methadone. Suboxone, they use the film, and they provide that in the regular medication line, whereas Rhode Island uses a separate medication line, a whole separate process for Suboxone film. Rikers also has a therapeutic community with an abstinence-based model, but people can be on MAT in their abstinence-based therapeutic community. So again, as I mentioned earlier, there's a lot of the world is evolving as to how MAT fits into abstinence and treatment. Let's see. They also provide at Rikers naloxone kits to visitors. So when people come into the visitor lot and sit in the visitor center waiting to be bused to the prison, to the jail that they're the person they want to see is in, they can watch a video and take a little quiz on naloxone, and on their way out they can turn in their signed little form that says they've received the training and they want the kits, and they get a kit at as they leave the island. New York, in terms of outcomes, has seen twice the rate of adherence in outpatient treatment when methadone is continued during a jail stay compared to when they have to withdraw people from it, which is pretty striking as well. Holly and Dr. Lindsay, any other comments on Rikers before we quickly talk about lessons learned?
No, I think Rikers, their methadone program was impressive and obviously one of the oldest in the country. And I think what we took from there and the advice from the leadership was that we started thinking about having our own OTP program within the jail system, because before that, the only path we thought of was to contract with the community providers. And I think that was a message we took from Rikers, and that's what we're going to be working on long-term plan here.
They've been their own NTP program from the beginning, and they wouldn't have it any other way, though, as they're considering how to shut down Rikers and move into borough-based jails. It's going to be a challenge trying to figure out what to do with that single NTP license. So lessons learned, these are some of the things that we took away from this experience of visiting both of these very unique places. First was that there really is an obligation to build an understanding across all the healthcare and custody staff about addiction as a disease, about treatment objectives, and about treatment tools, and give people an opportunity to talk about their prior experiences and perceptions about abstinence versus medication, and about the MAT meds themselves. Training, and training. Can't do it. You can't overtrain people on this stuff. We also learned that there has to be a very strong partnership between custody and nursing to design strategies to reduce drug diversion, which is the biggest objection that we see out there to introducing these drugs into the correctional settings is drug diversion. There's all sorts of data, and we could spend a whole nother hour talking about what diversion even means, but that is a strong concern that needs to be respected, and building good medication administration practices is critically important. We also learned that you really shouldn't even do this if there isn't a treatment system that can sustain it in the community, because that's where the lives get saved. When people leave, if they stay on treatment and are in treatment in the community and don't start reusing drugs, those overdoses don't occur. We also learned that people have different treatment objectives. Individuals should have their treatment objectives respected and honored, including abstinence. And we learned that you really need an excellent data system and evaluation plan to really tell what happened and be able to build support for ongoing treatment of addictions. Holly, Aristu, other lessons learned?
No, I think that you summed it up pretty well. That from what since the trip we had, the tours, we are now seeing more of the importance of the training at all levels, different disciplines, and also developing a good evaluation system, as you mentioned. That is hugely needed in any system from the start of the implementation of the program.
And I think also part of being able to develop these relationships with both the corrections and the healthcare staff, we've been able to communicate with them and ask them questions about policies and procedures, and they've been very open in sharing with all the information that we have so that we don't have to start from scratch.
So moving on to what's happening in LA, I'm going to turn this over to Holly and Dr. Amenziadeh to describe what goes on in LA County Jail System and how they're preparing to address and are addressing addictions there. So go ahead, guys, and I'll just flip the slides as we go.
Okay, well, welcome to Los Angeles County Jail System. On average, we have about 18,000 inmates across 6 jails here in Los Angeles County. Approximately 68% of those have a diagnosable SUD, and 70% are co-occurring mental health and SUD. These are mirror the statistics that you're going to see nationally. We're probably even underrepresented here in those numbers. Of these, approximately 18% have an opiate addiction. We did kind of a down and dirty survey here. We interviewed 3,000 inmates over a 2-week period, and we came up with, I think it was about 17.6% self-reported that they were using opiates. Out in the community, we have a partnership with the Department of Public Health. They oversee all of the addiction medicine services within LA County, and their stats also say at this time it's 18%, with chances of we're probably going to see an increase here. Next slide. In January of 2017, the Board of Supervisors approved funding to create jail-based substance use disorder services to treat 500 inmates on any given day located in 4 jail facilities. Around the same time, I think it was about a year prior to that, the Board of Supervisors moved to create a correctional health system, and the services had been provided by the Los Angeles Sheriff's Department and now are overseen by the Department of Health Services. So at that time, they put together a leadership team as a director of mental health, a director of medical services, and they also included a substance use disorder director. So the Board of Supervisors at that time saw the need and have dedicated some funding sources and put behind it so that we can provide services up to 500 people. We decided we had very limited services, as you can tell, if we're talking about, 68 to 70% of the population here having an SUD, 500 inmates is not very many people that we're serving, at least delivering substance use disorder treatment services to. So we decided to look at some very high-risk populations. So we put into place gender-specific programming for both men and women. We're also providing services to the gay and transgendered population, which is a very underserved population within the community of corrections, and also to the co-occurring mental health. So this is mild to moderate mental health and with substance use disorder services. And what the program that we've developed here is developed with ASAM criteria. So they're assessed using the American Society of Addiction ASAM, and the ones who are being provided services at the highest level right now is 2.1 or above. And I'm going to pass this off.
Okay, so I think the overall the change, and we're trying to incorporate the management of addiction into the mainstream delivery of healthcare here in correctional health at LA County jails. What we're planning to do is to integrate the treatment of addiction into the patient-centered medical homes. We're going to be developing the CHS delivery of healthcare will be through the patient-centered medical homes with primary care as the first line of delivery of care, and then they're going to be incorporating the addiction into it. The vision is to be able to provide all FDA-approved medications to our patients, and if you think about it in a medical model, we should be able to have all the medications available to us, so we can individualize the treatment plan based on patients' needs and also their intensity of addiction. And we do believe that medications should be associated with the psychosocial therapies that are provided through our START program. What we're planning to do is that every patient that is being enrolled into the START program will be also referred based on the ASAM level of criteria and requirements, frequency of visits by our primary care or addictionologist, to be referred to the what they call the MAT line or the addiction medicine hubs within the patient-centered medical homes for initial evaluation and to start them on MATs as they see fit. Next slide, please. The current medications that we do have on our formulary are acamprosate, buprenorphine, disulfiram, naltrexone in oral form, and also the long-acting injection Vivitrol. The buprenorphine is being used primarily for our pregnant patients. These are the patients that come in suffering from opioid use disorder, either maintained on buprenorphine in the community or they were identified as using heroin or any other opioids. They're going to be if they are not being maintained on buprenorphine, they will be transferred to an high-risk OB inpatient ward at LA County Hospital. Once they're maintained and stabilized on a dose of buprenorphine, they'll come back to the women's jail, CRDF, at LA County Jail, and then will continue their medication throughout their stay. And then the aftercare or the transitional care team will start the process of their community care and after release planning. So then they will be continued on their MAT and buprenorphine upon release, and also referred to a tertiary OB clinic so they are equipped with delivery of the infant in a patient and a pregnant woman who's been using buprenorphine. For naltrexone, oral is also available, and also we're offering them the injection. Next slide, please. As Holly mentioned, our patients are being screened through by the ASAM triage tool, and the services are going to be geared towards the level of care that they require. Starts from the SPIRT at the lowest level, and then what the START program currently offers, something equivalent to 2.1, an IOP level of care, which we see in the community. And then what we're proposing to the board with increased fundings to be able to offer up to the residential care treatment here. Our detox pods would be equivalent to a 3.7 ASAM level of care. Our first detox pod is a medically monitored withdrawal management pod here in jail. And then obviously our patients who are requiring a higher level of care will be coordinated and transferred to the jail ward at the LA County Hospital for stabilization before they return back to us. Next slide, please. What we're currently working on in terms of the levels of care to using the medications to treat addiction at the levels of patients' withdrawal management, and also if you divide it into maintenance management. For the withdrawal management, I will talk about in the next slides. We're developing, currently have we started based on the number of patients we have. Alcohol, it's one of the major drug that patients use upon admission to our jails. So the first pod that was opened is used specifically to manage alcohol withdrawal. The next phase that we are enrolling is the use of buprenorphine for opioid withdrawal management with those pods, and then also the benzodiazepines. The way our system is now working, most of the, as of now, all of these are nursing run protocols, which are these, we develop these set formulas and policy procedures that are mainly run by nursing, and we have daily visits by our clinical pharmacist that sees the patient and then refers the high-risk ones to the physicians for reevaluation and adjustment of meds as needed. Future goal would be to manage the mild to moderate opiate and alcohol withdrawal management through the medical homes as an outpatient basis. And next slide, please. When it comes to buprenorphine, as I mentioned, currently we are only using it for pregnant patients, and soon we're going to be using buprenorphine to manage our withdrawal management in the opiate withdrawal detox pods. We're still exploring the options when it comes to buprenorphine maintenance, whether to maintain patients on buprenorphine throughout the incarceration with us, or induce them 7 to 10 days prior to their release. So this is something we're still exploring and looking at data to see which one works better for our system. Naloxone is being used. What we're developing in use of naloxone within the jail is going to be implementing an opiate overdose emergency response training for our custody and our nursing staff. We do have overdoses, and it does happen within our system, and we don't see much of a naloxone being used. So I think that's what's being done to train nurses and the first responders within the jail how to use the naloxone and when to use it. At the same time, there's going to be patient education throughout the jail, either focus on our START program. These are the patients who are currently enrolled in our IOPs, and we have MAT education groups that target that population, and also throughout the system. For the release, it's going to the naloxone kits are going to be delivered by our whole person care team. These are our healthcare transitional team, which it's a whole different department that takes care of the release planning and aftercare and linkage of our patients to the community. And they're going to be taking care of the ensuring that our patients will receive the naloxone kits upon release. Next slide, please. Naltrexone is one of the first MATs that we start using for patients who are interested and are qualified, and there's indication for it. What we'll do, we'll offer them the oral pills throughout their stay, and that's a coordination, a close coordination between the care transition team and the health delivery, the physicians, that they'll be notified of the upcoming releases, and about 7 to 10 days prior to release, they will get their first injection of the long-acting naltrexone, Vivitrol, and then they also will be linked with a community provider which offers MAT for the further treatment with medication and also enrollment into their psychosocial therapies. Next slide, please. Methadone is the one that it's one of the top priorities that we're currently working on. We do see a good number of patients coming to us on methadone, which are maintained in the community, and we're developing a plan to offer them maintenance throughout their stay. I mean, we just did a very brief survey over a week of our admissions, I think, and we found that comparing to the national data and the data we have only 50% of our opioid users, our substance users, report their use upon admission to jail on arrest at the initial intake. So considering that only 50% reported that, we had about 20 patients on methadone over a week. And these are the patients that are currently just being withdrawn, go through the regular withdrawal management and being withdrawn from methadone. So the plan would be to continue their dose, that they were stable in the community within the jail. The short-term plan, we're working on contracting one of our community-based OTPs to deliver methadone within the jail. And the long-term plan is we're going to be applying to become licensed to have the correctional health OTP within the jail. Next slide, please.
Okay, I'm going to talk about, you've heard us talk about the START program. START stands for Substance Abuse Treatment and Reentry Transition Program. The START program is a collaboration between the Department of Health Services and the Los Angeles Sheriff's Department. This was a project that we started probably about 3 years ago, and it was in response to AB 109 here in California, which now people who normally would have gone to prison are now serving their prison terms as jail sentences here in Los Angeles County. So before AB 109, on any given, any inmate was probably staying maybe a length of stay of about 42 days. That has now extended to over 60 days, and some of the inmates here are serving sentences that are 10 years or more, as well as probably the average AB 109er is here for about 12 to 18 months. So it seemed appropriate that we should be providing substance use disorder treatment services here within the jail. This was implemented in May of 2017, so we're really just coming up on a year now, and we've implemented START services at 4 jails. And we're serving the populations that I talked about before. We incorporated this into the sheriff's what's called education-based incarceration program. These are where the sheriff offer a variety of programs. Their GED inmates can get their education here. They can get college credits. They can get vocational and social skills services, and they get what's called milestone credits. So these are credits incentives to participate in programming. So we felt that substance use disorder, we kind of needed a carrot to incentivize them to come into treatment. And so they receive one of these milestone incentive credits for participation in the program. For every 60 hours of treatment, they receive 1 milestone credit. So they get 1 week off of their county jail time. Next slide. So the objectives of the program are to make sure that SUD treatment is available, that it's evidence-based, integrated, and high quality, that it's measurable and driven and made available to every inmate. That's our goal here, is that every inmate who wants some level of care, whether it's medication-assisted treatment, whether it's treatment, or referral to treatment, gets it. The other goal is that we want to increase the use of addiction medicine, so we've incorporated within our START program education modules that talk about medication-assisted treatment. We have our clinical pharmacist who goes in. We've had fellows who are doing their fellowship training here, rotations.
Yeah, we are one of the sites. We're one of the rotation sites for our UCLA Addiction Fellowship that they rotate through our department here.
Yeah, so we've incorporated them into our presentations that we do to the inmates. Obviously, effective reentry planning to support and sustain a recovery. Here in Los Angeles, as well as across California, is the 1115 waiver, which added drug Medi-Cal and expanded the benefit. So we've linked to the Department of Public Health substance abuse system of care. So we actually link them to treatment, and we provide transportation to treatment. So of course, our overall goal is to improve their quality of life and their overall health outcomes, and to reduce crime and recidivism. Based on the research that I've looked nationally, it's anywhere from 5 to 25%. I don't think we need to really make the case. We know that substance use disorder treatment does reduce crime and recidivism. Next slide. Our START program is voluntary, unless it's court ordered, but it's still voluntary. They just have an option of either extended jail time, or they can be in the START program. It includes both pretrial and sentenced inmates. We work very closely with our drug courts here in Los Angeles County. We have 10 of them, and the inmates are required to do county jail time and START up to 90 days. And then they continue with treatment in the community for up to a year. We also get referrals from the Public Defender's Office for their pretrial defendants, in hopes that participation in the START program will impact their sentencing recommendations. Other courts have now started to order its defendants into treatment. We just started working with the AB 109 Revocation Court to provide START treatment services to AB 109 probationers. In the 3 of the 4 facilities, we are delivering ASAM level 2.1 services and what we would call a sober home. They're all housed, they're cohorted together in a dorm setting. Depending on the facility, we have upwards of 130 or more inmates in a dorm setting, where they're receiving up to 9 to 15 hours of evidence-based group and individual counseling. It's a 15-to-1 caseload, so for every 15 inmates, they have a substance abuse counselor, they have a case manager, we have a program manager that oversees the program, we have a licensed or license-eligible social worker that's attached to the program. We do provide what we feel is the most appropriate therapies for this particular population, which is cognitive behavioral therapy, motivational interviewing. We do use trauma-informed approaches, and we're also using interventions to address the criminal thinking. The setting is evolving into a therapeutic community based on residential substance abuse treatment, the RSAT standards of care. Next slide. As I mentioned before, we're about a year into the project, so this is just a snapshot. On any given day, this is what our population looks like. So as of April 30th, 2018, we're serving 63% of our goal of 500 inmates on any given day. In our women's program, we have 93 men, we have 112, gay and transgender, we're serving 68, and we have 46 in our co-occurring treatment program. Our goal is by the end of this fiscal year, we'll be serving 75%, and then the first half or the first quarter of our next fiscal year, we will meet our goal of 500 inmates on any given day. Next. These are just some very basic metrics based on our first year. So from January 2017 to January 2018, we screened, and we're using the ASAM screening tool, 251 inmates. 248 of those accepted treatment. So we know if it's available, they will accept the treatment. Of those, 230 completed treatment. Completed treatment means that they at least went through an 8-week cycle, and 18 did not complete treatment. Next slide. I think that's it. Thank you.
we covered a lot. This is Donna, and a couple questions have come in on the chat screens and things. Let's take those, and then Challen will help us figure out how to take other questions in discussion. First question was a while back. It said on slide 10, you're saying that this was about Rhode Island. A third of the female detainees were on MAT. The question is, were they a third positive for opioids and are now on MAT? That's correct, but there may be more than that who are positive for opioids and not on MAT. But yes, the prevalence of opioid use is far higher on the East Coast than the West Coast. It's a bad problem here. It's hellacious on the East Coast. And indeed, a third of the women in the Rhode Island system are on medication-assisted treatment for opioid use. There was another question about a statement that was one of our lessons learned from Rhode Island and Rikers, that you need to build a treatment system inside correctional settings that can be sustained in the community. So the question says, so if agonist and antagonist treatment for SUD is not available in the community, when a person is released from incarceration, should the jail or prison not start such a program? I'm going to ask Kelly to chime in on this. My response is that most of the communities in California are trying to figure out how to make agonist and antagonist medications available. And as I mentioned earlier, if you view the jail as a stop in the community system of care, it should be integrated with what the broader community is doing. So if those treatments aren't fully developed in the community, at a minimum, the jail should be involved in processes to develop them. Kelly, Dr. Pfeiffer, do you want to add anything to that?
Right. I mean, what I've been hearing is that we can't make perfect and the enemy of good. I mean, everyone should have access to comprehensive behavioral health services, yet we have good data that death rates are cut in half by Suboxone, whether or not behavioral health services are offered. Likewise, we don't want to get in a chicken and an egg of that we can only start treatment in emergency departments or jails if we have a robust relationship with the outpatient treatment provider, because often these things can be developed in parallel. Since there's so many opportunities now to create access touch points. We have a telehealth provider who's been able to offer MAT through the use of a phone or an iPad, and they are partnering with emergency departments who can't find community providers ready to take the patient. And as people develop programs in jails, they are trying to build these relationships with the community. Sometimes it's hard just because these are organizations who don't often talk to each other, and they may not be aware that there is a treatment provider willing to accept the patient because they've never had those conversations. So there's so much energy in California right now, and frankly, a lot of money going into treatment with the $89 million federal program that is supporting MAT at lots of different touch points. So we certainly hope no one is stopped by the lack of a partner, because by starting to do the work of building the program, you'll find yourself developing the partners you need.
Thank you. There's another question that's a real kicker. It says, what strategies do you employ to help critics overcome the stigma that may have been applying to MAT in people with SUDs, and what would you recommend to regions just starting to grow MAT and continuum of care options in correctional settings? So it's a really important question. From my experience around the country, first and foremost, I think it's important to recognize that people have different opinions, but they also have different levels of understanding of addiction and addiction treatment goals and tools. And so bringing people together in a collaborative setting that allows discussion to occur to raise the floor of understanding about addiction and about treatment options across the stakeholders is really important, as is the freedom for people to speak their mind and for each community to find their unique version of a solution for them. We see across the country everything from sheriffs who radically oppose any drugs inside their jail, and they consider these drugs, to sheriffs who can't quick enough get a good MAT program going, and everything in between. And there are courts, and there are community doctors, and there are the nurses that work inside, and there are the public defenders, and there's everybody, a lot of stakeholders, as you all know, involved in the discussion. To my mind, one of the best initial activities is a discussion and education that allows people to see this problem of addiction through a lens that is, if not precisely the same, at least similar across the stakeholder groups. And we're going to talk in just a moment about some opportunities here in California to help with those kinds of discussions. But let me ask Holly and Kelly and Dr. Abinzadeh to comment on this challenging question as well.
Yeah, I think when we included LASD when we started in the development process of implementing addiction medicine services here in custody, and as we've opened up each of the programs and each of the different facilities, we've had to bring stakeholders in again and constantly educating everybody. It's a constant education about the need for services, but the feedback that we get is once the program is in place, whether it's they're receiving medications or they're participating in treatment services, is that most of the line staff from the custody all the way up just say, you know what, our number one problem is substance use, okay? We all know it's here, and now we're so happy that we're actually addressing it. And we're going to be having, we've had kind of, again, we're such a large facility, we're having conversations in silos. So we're having conversations as we're developing it with our healthcare providers, with our mental health providers, and then also with custody staff. We're having a summit at the end of this, at the end of May. And actually now we're bringing everybody together, and we're going to talk about what we've done. We're bringing in subject matter experts, you know, to talk about addiction, you know, just as a chronic illness, and then how we're going to address it, and then how we're going to build it over the next few years.
And I think just to add to that, what has helped, as Holly mentioned, is to talk about chronic medical illness and management of a chronic illness. And stigma is nothing that will go away anytime soon. These are deep-seated beliefs. So then we can't, and realistically, you can't get rid of the stigma and wait for it to go away, then start. What we did, we still see it in all levels of our personnel, from the frontline clinicians, nursing, and all the way to some of the, to be surprised, some medical leaderships. It's still there, but they're doing it because, to be honest, there's no option. You have to provide a care for someone who's suffering from this chronic illness. What has helped us is educating, and also at times I'll go down and nursing staff are sitting there, we'll have patients coming withdrawing from opiates and in a bad shape, and just for them to see how the patient responds to a single dose of buprenorphine, that has a significant impact on how they see and change their attitudes towards our patients and towards treating them.
That's true.
This is Kelly Piper. If I could just chime in. I mean, I have been shocked by watching people change their attitudes. The stigma is not easy to change, and culture is not easy to change, but by hearing the data, by talking to people like them, like the warden at Department of Corrections in Rhode Island was a powerful voice, and she said, I used to oppose it completely. Suboxone was stuff I kept out of my jail. I saw people's lives being saved and inmates transformed, and I've changed. And hearing from people who are in custody, not just the medical side, is a very powerful story. So people who can be powerfully opposed and change once they are either exposed to new ideas from people like them, when they're exposed to the data, or sometimes just listening to their concerns and making sure that we on the medical side don't trivialize real concerns about diversion and safety.
Absolutely. And this is Donna. I would also say that there's some good data out there now. It's pretty new, but it's very compelling for people on the custody side about how when you treat addiction instead of force people into withdrawal, altercations and chaos on the unit decreases visibly and measurably. and that is a pretty strong selling point. It sells itself, actually. I also, there's a question about what is your process for educating stakeholders? And I want to just go to the next slide about that, because there's two things that we want you to know about, you California people that are on the call today. One is the virtual network that we've been running. Kelly's been organizing it for over a year now, of jail MAT providers. We hold calls every other month to share experience and information, and it's primarily made up of clinicians, and but there are other stakeholders as well. So that's an option for those of you that are directly involved with jail MAT to seek out. Also, the Department of Healthcare Services in the next few weeks, in June, will be issuing requests for applications for California counties to participate in a year-long learning collaborative if you are interested in advancing the use of MAT in your county jail and drug courts if you have drug courts. MAT in this case means at least 2 medications, so there has to be an agonist, and up to 20 counties are going to be selected. Teams of key stakeholders from the counties will be applying, and it'll be, the project will afford those county teams a year-long learning collaborative, which will involve 3 in-person conferences with all of the counties together for education and sharing experiences, resources, monthly coaching calls, and technical assistance at the local level. So if you're interested in educating your stakeholders, this is the process for you. It will also provide funds to cover local travel to the events and things like that. So we're going to be issuing this request for application broadly. I think if you want to get it personally, you could email me directly and I'll make sure that you get it. Kelly, do you want to add anything?
No, we're just very excited to partner with the Department of Healthcare Services on this work. It's critically important, and I think we're going to see a big shift in California over the next few years. So thank you so much to everybody for sharing your stories and your experience. We're really grateful to work with Donna and Holly and Dr. Aminzadeh, and please do reach out to us if there's topics that you'd like to hear from California Healthcare Foundation on this webinar series.
There was one more question. I'm going to give this to Holly. What's your data and evaluation plan, and what's the platform that you're using?
We're collecting some performance measures now. We're going to be adding more in the next fiscal year, and we're looking for funding actually at this point for an evaluation plan. And
actually, oh, go ahead. In the learning collaboratives that I mentioned, one of the features will be county-specific facilitation on setting up a good data plan that can particularly track overdose deaths that occurred in people who had recently been incarcerated, as well as engagement in treatment, reduction in recidivism. A couple other quick questions came up. We do have 2 more minutes. Clarification, do inmates receive treatment in the LA hospital or in the jail? Holly, want to talk about that?
Go ahead, Eric.
This is our, it's generally in-house, and the only patients that are being transferred to LA County Hospital are pregnant patients who are currently on opioids and heroin. They'll be transferred to OB high-risk clinics, inpatient at the LA County Hospital to be stabilized on buprenorphine, and then they'll come back to us. But the rest of the treatment is in-house within the jail.
Yeah, we have 6 jails here in LA County, and we currently have START treatment services in 4 of them, and our plan is to expand to all 6 next fiscal year.
And there's a question for Kelly about how the slides can be accessed. Will you be putting them on your website?
Yes, the recording and all slides will be available on our website no later than a week from today. So we are out of time. I want to thank everyone for participating, and I hope you all have a good afternoon.